with Associate Professor Cristian Dinu from Romania, who is part of the department in the maxillofacial and oral surgery in Romania, in the university. And his topic will be about biological and technological factors influencing the aesthetics of a single and multiple implant restorations. So please enjoy.
Thank you.
Professor.
Thank you for your nice presentation. I'm very happy to be here in this beautiful morning in Sofia, and I welcome you. I really appreciate that you were waking up so early to attend this meeting, and I will try to give you back this effort, discussing today about what is influencing the aesthetic restoration on implants, and then we will go through for the live surgery, and I will show you the present time of implantology. What means one-day implant, what means guided implant placement and immediate loading. So the patient will come in your practice, and in half an hour, he will go out with the implants and with the provisional crowns. So this is what we can nowadays achieve by these implants. So a few words about me. I'm from Romania. I'm from Cluj. This is on the same line with Sofia. We are here now, and I live in this city, and it's on the same vertical line. So I think this is very common, but I have to fly around because we don't have a direct flight. My city is the capital city of Transylvania. I know you heard about. This is the northwestern part of Romania, and this is famous for one guy named Dracula. It doesn't exist, in fact, but it's a beautiful city. It's like yours. It's a very cosmopolitan university city. We have 7 universities and almost 100,000 students overall. So I'm also part of the University of Medicine and Pharmacy. I'm a maxillofacial surgeon in everyday practice. So I go to the hospital, and my daily practice is microvascular reconstruction, plastic surgery, malformations, craniofacial surgery, trauma and stuff. And of course, in the afternoon, because you know the situation also in Bulgaria is the same, we have to go to the private practice, and there advanced implantology and implantology is my topic. So I'm lecturing about this since I think 2012. Let's go through our topic, and our topic is about aesthetic area. Why we talk so much about aesthetic area? Every dental meeting, like this one, which is a very famous, maybe the biggest in the Eastern Europe, have a lot of topics about aesthetic area. If you take a look in the program, many meetings, many speakers will touch this area of aesthetic importance. But why? Why it's so difficult to restore and to make perfect a restoration in the aesthetic zone? What do you think? Because we see this. We see this. These are photos from my practice, and this is not implant placed by me. And we see this. We still see this in 2019, and we don't like. And this is a problem, because our patients are in conflict with us. It's very demanding, for sure, and you have to take care of all the details. And today, I propose you to go through all these details that makes you successful. And also, in the last part of my presentation, I will show you also the management of complications, because complications appear, and a good doctor is that one who can solve the complication successfully. My agenda will be some biological consideration. This is maybe the boring part of my lecture, but I want to be sure that we speak the same language. And then we will talk about the factors influencing the implant aesthetics. What should we fine-tune to get this good result? Clinical protocols. We will go through all possible situations in the frontal zone, even if it's single restoration, multiple, or a full arch. And then management of complication, and we will try to have a message. And after that, I will present you the case. Our patient is here, and we thank him a lot. And we will make a guided placement of the implants and immediate loading. So it will be a full morning. Let's go through our topic. So biologic consideration. One, we have to know when we begin to restore a frontal area, aesthetically, of course. First, we extract the tooth. But what's happening? When I was a student 20-something years ago, they told me if you immediately place an implant in a socket, you will stop the remodeling of the bone because the implant will give forces to the bone and the bone will have the stimuli for being there. Is it true? I'm not sure, because if you go to the literature, you will see this is the consensus report of a big group, osteology, from 2011, and they say that after the tooth is extracted, we experience a major restoring of the bone and of the soft tissue, and we lose bone 2/3 within the first 3 months. Why we lose this bone? And also, there are studies on CBCT, which is an amazing tool. We have it now, and there are many studies, like this one with a burn group, Vivian Chapuis and Boozer, in which we have a lot of horizontal bone, from 3.8 millimeters to 6.1 millimeters, especially on horizontal. Yeah? Our ridge will be thinner. This is very important because it's compromising our aesthetics. Yeah? Why we lose the bone? Why we lose the bone, you know? Something it's happening there. We have an apparatus. The tooth, it's in the socket in connection with the periodontal apparatus. This means cementum, this means periodontal ligaments, and there is a bone, we call it the bundle bone, which makes part of this periodontal apparatus. When we extract the tooth, we, in fact, destroy this stability, this apparatus, periodontal. So we will lose the cementum, because it goes with the tooth. We will break the periodontal ligaments, and we will leave there the bundle bone, the bone in which these ligaments are inserted. But it is proved scientifically and clinically that this bone will disappear within some weeks. Yeah? 6, 8, 10 weeks, we will lose the bundle bone. Yeah? That means if we had a very thin buccal plate, we'll lose it completely. Some people said immediate implant placement will stop this, but there are many studies, like this one of Cardaropoli, that after implant surgery, the remodeling takes place. Even the implant is there. Yeah? In 6, 8, 10, 12 weeks, we will lose that bundle bone. And there are other studies that show that a tapered implant is much better than the cylindrical implant because we'll keep the bone better. Mariano Sanz from Madrid showed that significant bone reduction happens irrespective of immediate implant placement or implant geometry. What happens if we cannot place immediately an implant? What happens? We have, in 87% of the cases, a buccal bone plate less than 1 millimeter. And even worse, 50% it's less than 0.5 millimeters. This is a thin biotype, which is a high-risk situation. Yeah? Less than 1 millimeter wall of bone we have in the normal practice when we try to place an immediate implant. So, what are the risk factors? What we should take in consideration when we want to immediately place an implant in the frontal zone? And I really like this paper because it's a very consistent study of Jorge Ferrus. And the conclusion of this study is that this remodeling of the bone after implant placement is related to the thickness of the buccal bone wall and the horizontal gap. Yeah? How big is this part of bone? And how much space we have between the implant and the buccal bone plate. That's why in the frontal zone, it's indicated to have thin implants, small diameter implants, because we want bone around the implant. We don't need a big piece of titanium because it's not biologic, it's not a living tissue. We want living tissue around the implants because all our problems are with the living tissues. We have problems with the bone and with the soft tissue. Very hard we have problems, technical problems with the implants. It's less than 1%. So we have to take this in consideration, and like a conclusion, we have to understand that first, immediate implant does not prevent bone remodeling. It will occur. The second, the back and bone plate is less than 1 millimeter in more than 80% of the cases. So it's very, very thin. And the third one, the thickness of this buccal bone and the dimension of the gap are influencing the remodeling of the hard and the soft tissue. So let's try to think about this. It's not only the bone, it's also the peri-implant mucosa thickness. Yeah? There are many studies showing that a thin mucosa, the vertical mucosa, thickness of the mucosa, are influencing the bone stability. When we have less than 2 millimeters of the thickness, we will lose more bone than if we have more than 2 millimeters. And Berglund, Linde, Linkevicius, with this, his zero bone loss concept, is that one that's saying you have to consider that 3 millimeters of thickness of the mucosa around an implant would give stability of the bone. If you have a thin mucosa, you will lose more bone than if you have a thick mucosa. And this thing, it's very important. It's even more important than the implant abutment connection type. If you have the appropriate dimension of the mucosa, the connection is not so important. If you don't have it, yes, a conical connection is much better than the other one. But if you have the biologic background, bone and soft tissue, you will have a very, very comfortable situation. And I will emphasize this in all my lecture. The living tissues are very important. Yeah? This peri-implant mucosa thickness is have the capabilities by vascularization to keep the stability of the bone. We need thickness of the mucosa, and we also need attached keratinized mucosa. Keep in mind, and we will see that with our patient. So in cases with a thin biotype, we have to improve our thickness. How? We have to graft. We have to improve the thickness around the implants. It doesn't matter if it's frontal area or it's the lateral one. We try now to understand biology and to make biology work for us, because if we will stand against the biology, we will not be successful. What about aesthetics in implantology? What do you think there are the factors influencing aesthetics? When you want to place an implant in the central incisor, what are the factors taken in consideration to be successful? Nobody? Okay, it will be a monologue. You don't want to talk to me. So there are 3 important factors in this aesthetics. The length of the crown. Yeah, the prosthetics is very important, but we need to be sure that the crown is perfectly designed. We have to have the base, the background, which is the 3D implant position. If we place in a bad position the implant, everything will be ruined, immediately or in time. We have the bone, and we have the soft tissue. These 3 elements, 3D position, bone, and soft tissue. This is to be kept in mind when we plan a restoration in the frontal area. And these are the rules. You all know the rules. Minimum 1.5 millimeter from the neighboring teeth. Or keeping, it depends on the connection. If it's an undercrestal implant, you can go up to 4 millimeters. If not, if you stay 2.5 and 3 millimeters from the zenith of the adjacent teeth. Yeah? So this is the transition zone. And it can be from 2.5 to 4 millimeters. Many people say 3 is okay. 3.5 is the medium distance. And then you have to keep at least 2 millimeters of bone in the buccal plate, yeah? To be stable in time. It was proved scientifically and clinically. We see that we need 1.8, in fact, but this is more or less 2 millimeters of bone. So we have to place our implants a little bit more palatally in the frontal area. How can we control the 3D position? Because it doesn't matter if we have beautiful tissues, but the 3D position is very important for the loading and also for the aesthetics. How we control it? What do you think? By freehanded. You have to take some landmarks and to be very smart, orientated, three-dimensionally, and to place well the implant. But you have many obstacles. For example, the angulation of the mandible. You will see in today's case, we are on the lateral area of the mandible. The mandible is doing like this. So if you're placing the implant on the right position, you will go in the submandibular fossa and you'll have some problems. So this controlling the position, especially when you are not very experienced at the beginning, you can be helped by what we name the guided implant placement, or the guides. And we will do this, because it's the present. It helps you, it helps me, it helps everybody, because we can plan the position at home or in the office, very relaxed, not during the surgery, when we can have some more difficulties to place perfectly the implant. And we have the static surgical guides, and now they are developing the dynamic ones. So you see where the burr is directly on the screen. But if you have the static one, you will see that is great. I'm using it in easy or in complex cases, and it's not a big deal to do it. And when you will leave today, you will know how to do a guide and what is important for placing a guide. The second is the tissue, the hard tissue, the bone, and the soft tissue, the gingiva. How we compensate this resorption? We have to graft. We have to graft the gap. We have to graft the socket after extracting the tooth. And we have to use biomaterials. And we like the slow resorbable biomaterials because they will keep the volume. And we have DBBM, which is a xenograft, or we have the allograft, which I like the most, in fact. Allograft is great, and you have a very good allograft here in Bulgaria. It's named Allodin, and I'm a big fan of this. Also, using the membranes, the resorbable membranes, sometimes when it's needed, and we will see when it's needed to place a membrane and when it's not needed to have a membrane, it will reduce the resorption and will improve the BIC. What is BIC? Bone to implant contact, the surface between the implant and the bone. And also using the connective tissue graft. And there are studies, Uli Grunder and Zula have shown that placing a soft tissue graft will reduce this resorption. And also, connective tissue grafting is great, but when proper three-dimensional implant position is achieved and the bone is grafted. So if you only graft soft tissue, sometimes it's not enough. You have to place perfectly the implant and to graft the gap. And I think now we have an idea about this. Where from we take the soft tissue? We saw where from you take the bone, from the little bottle. And you can mix it with some autogenous bone resulting from your site preparation. It's easy. You just make a very small rotation and not placing a lot of liquid, and you can harvest, and the Megagen kit has a very good burr for harvesting bone and then mixing with the biomaterial. A soft tissue, I prefer two places. The first one in my practice is the tuberosity. Why? Because it has a beautiful lamina propria. It's not at all traumatic for the patient. They don't know you harvested some tissue from there. It's very, very, very low sensitivity in that area. And you have a lot of volume. Look at this volume. You can just cut it, remove the epithelium. This is the epithelium. You can remove it, and you can have many, many slices of CTG, and you can place it buccally, lingually, around an implant, make a hole in this, and put the healing screw and increase the thickness of the tissue, what we were discussing before. So tuberosity is always great. You can cut it, and you can do small 1 millimeter, 1.2 millimeter pieces of connective tissue graft. The second is the hard palate, but is the subepithelial is the best one. So I prefer to harvest this graft from the molar area, just like a free gingival graft, epithelium and connective tissue. And after that, what I'm doing, I'm removing the epithelium, and I'm removing the fat tissue and the glands. And what is left, it's something like this. It's a white, dense, firm, beautiful connective tissue graft to be grafted. And this has a beautiful potential of growing. You place it, and you see that after 3 months, 6 months, 1 year, it will grow, it will improve. And I will show you on the cases. And I finished with the boring part, but it was useful to have the same discussion, to have the same idea about what means aesthetics. Now, I propose you to go through clinical protocols. Different, all of them, there are not two the same. Yeah? Different clinical protocols, and I will explain what was the reason of choosing the solutions, keeping in mind 3 situations: 3D position, bone, soft tissue. This is the 3 important things in aesthetics. Yeah? And this is a very difficult case. She was 17 when she came first to me. And you know, it's a discussion about when to place an implant. Yeah? I advise you to place it after 18, 19 years old, because the maxilla is still growing, and even if it's not developing transversely, the maxilla is having a rotation, a clockwise rotation, and you can have problems in harrying. I don't advise you to place implants in teenagers or until 18, 19, sometimes 20 in boys, in men. But she came with her father, and what do you see? It's a slight discoloration of the right central incisor. But when we quick look, we have a difficult case. Why it's a difficult case? Because she shows everything. She's a young, beautiful lady, and she shows everything. So it's a lot of pressure on you to restore the tooth with perfect result. Yeah? But why to restore? What we see intraorally, we see a fistula, a chronic fistula, and we see a not very beautiful composite reconstruction. Yeah? She's doing sport, and she had 2 or 3 years ago a sports accident with a fracture of the tooth. And you see the fracture is in the middle of the root. And the dentist was smart enough to just try to treat this root and to keep it still there. And he was successful for 2 years or 3 years. But in this situation, we cannot do anything. Look at the specimen. We don't have any periodontal ligaments here, nothing. Yeah? It was kept only by the fixation with the composite. And of course, the chronic inflammation at the apical half of the root. So we extract the tooth, we clean all the socket, and what we do now? If I have a fistula here, what means that? Exactly. So it's partial or total missing of the buccal plate. The book, it's telling me that I cannot place immediately an implant if I don't have an intact buccal bone plate. Let's see what is the rationale for choosing one or other solution. And looking in the literature, this is a Kahn classification of the position of the root in incisors. We have type 1, when the root is to buccal. We have type 2, when it's in the middle. Type 3, to the palatal. And type 4, this is the worst case scenario. This is the thin biotype, when you have nothing around the root. And fortunately, 81% is a good position. Yeah? We are lucky. 6.5 is in the middle, 0.5, so very seldom, is in the palatal position, and 1.7 is this situation, the most difficult one. So, taking a look at our CBCT, we see that we are in the first situation. So this is checklist green. It's okay. I could place an immediate implant. But let's see this Nick Elian's paper that saying we have three possibilities of damage of the alveolus. We have type 1, intact, type 2, partial loss, type 3, total loss. And looking at this table, we see that I'm somewhere here. The biotype is thin or thick. I have some pristine to slight damage, moderate damage of the buccal bone plate. So if I see the treatment recommendation of these guys, it's site preservation or immediate implant. Site presentation or immediate implant. So it was not clear for me. They give me both solutions. What should I do? I'm assessing next the risk. What means assessing the risk? You remember that table from risk assessment, and you try to check every situation. Situation first, it's lip line. Lip line is high. Yeah? Young lady, high expectations, thin to medium biotype. So my choice, she's only 17, so I have time, 17 and something. I have time. So doing this, I choose to make the site preservation and the implant to gain some time in the second step. So first, I have to graft and to improve the site. How? Preparing like a pocket in the mucosa, under the fistula, and placing a tuberosity graft. Why? Because I want to improve the biotype of the gingiva first. And then, here is the graft. I just solve the problem of the fistula. And what I'm doing next, I'm placing inside the allograft. I'm placing the allograft. I don't use the membrane in this situation. It's a good fixation of the graft. And this is the PRF. And this is the tuberosity site. Yeah? You see, it's only 2 or 3 sutures. The patient even doesn't know after the surgery that you have taken something from there. 10 days postoperatively, I try to keep the papillas in place. Yeah? This is only a transitional situation, and I will use here what we use usually, a Maryland adhesive provisional bridge, in order to keep this architecture of the gingiva, to keep this in place. Look at how much I added here. And in 6 months, after removing this Maryland provisional bridge, I have the papillas in place, and I have a very, very nice thick gingiva. Now I'm in a perfect situation of placing an implant. I have to choose now if I'm doing it guided or I'm doing this by hand. In this particular case, I'm doing this by hand. So look at the bone. It's beautifully, beautifully healed, and the soft tissue also. So I'm doing only a very small flap, or I can go flapless in this situation. It's a very small palatal flap because I don't want to touch at all what I obtained. Yeah? This is still, will stay there. And through this hole, I'm placing the implant. Yeah? What is nice, this is the position of the implant, and this is the position and the implant. And what is nice, if I have a good bone with these tapered implants, like any ridge, I don't have to wait for another 3 or 4 months to heal, because the geometry of the implant is so good that I have a great stability, primary stability in the beginning, and after that, the surface helps me a lot to regain a lot of integration. So the surface is important because I will have osseointegration very early, and the shape and the design of the implant gives me the possibility to immediate load it. And I immediate load it, I scan it, and I make the provisional immediately. Yeah? It's tend to lose some papillas, but they will come back. And this is the screw retained provisional. Never use cement in this situation. Don't use cement. Use just screw retained provisional. And this provisional allows you to work on this, to add or to remove, to shape the gingiva. And how long it will be? 2, 3, 6 months, until you reach the perfect position of the papillas and the zenith. And here the zenith was too low because of the graft. If you can see, this zenith was lower. So I used the laser to reshape it a little bit and to make the distal shape of the zenith, only very slightly, because the tissue was very stable at that area. Position of the implant, the good position of the implant, and now I change from, look, how is the color? It's so firm and so dense, the tissue that I placed it here. Of course, this color is when I'm retracting for the photo. Usually it's not so white, but when you retract it for the photo, you can see, and then you see the neovascularization of this tissue. Yeah? So it's a perfect integration. And look at this emergence profile. It's beautiful, huh? What can happen in this emergence profile? I have bone, I have the soft tissue, I have the papillas, it's cleanable, so it's the perfect transition zone. I have to make a special impression. So this is a special impression post. So we just make a customized impression post just to keep the same shape. You reach the shape with the provisional, and then you transmit it to the lab to make it exactly identical crown, but in ceramic. You don't change anything. And this is the end. I have the papillas. Usually, the problem is not the central papilla. You know, it's always the distal papilla. And look at this. The distal papilla in the restored area, it's better than this one. So if you see it, it's tend to say that here it's something because of the rotation of the lateral incisor. So this is the beginning, and this is the end. Nice shaped, very feminine shape of the crown. And this is her. She is smiling a lot. So you cannot miss the treatment with this situation because she's showing everything. And she's 18, 19 years old. Yeah? She needs perfect result. And also the father is pushing you to have the perfect result. So this is one case that you have to send it to your competition. And this is 2019. Look how stable it is. It increased a little bit, what I was talking to you, that this CTG is continue to, because he's got the genetic information of increasing the volume. And I proposed her to reshape with the laser, but she said she's very, very, very happy and she doesn't want anything else. So this is after 4 years. It's very stable. The tissue is very stable. And I think that in the future, with a good cleanability, nothing can happen with this. What we learn from this clinical protocol? So in single implants, we can use freehand placement, flapless, if we worked on the soft and the hard tissue. We don't want to disrupt anything there. The bone augmentation, it was partially missing the coronal part, and socket preservation with allograft and pericardium membrane, coverage with PRF, and we use the tuberosity graft with a pouch technique. The second protocol. So the second protocol is very interesting. This guy had an implant in 2014, immediate implant on the premolar, and after 1 year, I think, he came with a restored canine which is lost. So we have to make the extraction, and this was the extraction. Always take time when you extract teeth in this area. Yeah? Cut it. Don't put pressure on the buccal plate. Don't put pressure on the tissues. Try to be very gentle, not to touch the living tissue, because you will need this living tissue. You don't need these pieces. You can cut it in 100 pieces if you want, because you will throw them. But it's very important to keep the living tissues. Yeah? And this is what I have. Missing buccal plate. So in this situation, I will not place an immediate implant, because it's too risky. I don't want to risk. My patients have high expectations, and I don't want to risk. I could place an implant there, but with a higher risk. The same protocol, tuberosity, big piece of CTG with fixation, because there's nothing there, and because I don't want to have a fibrous integration of the allograft I place between the CTG and the allograft, I place a membrane. This is a barrier. Yeah? I don't want the fibroblast to go in the bone. Yeah? So I'm putting this membrane to separate the soft tissue that I grafted and the hard tissue that I grafted. Yeah? And this is the end. It's a membrane, it's a big piece of CTG, and it will be a Maryland bridge from the implant to keep the shape. Yeah? It's easy. It's nothing impressive. You just feel the whole. The patient doesn't suffer. He will not be with edema. He will not have a hematoma. It's a very simple surgery. You don't have to be a big surgeon to do this. And this is 6 months post-operatively. You have the old implant and you have the new site development. Well, I can say it's average. It's okay, it's average, like result. But I have good bone. But the patient is telling me, doctor, I waited 6 months. I don't want to wait anymore. I want today, if it's possible, the tooth. I want to have it very, very quickly, because you convince me that it's less risky to wait to develop the tissues that I lost. And what can we do? Wax up, scan. At that time, we didn't have the scanner, the intraoral scanner, but you can scan it with the intraoral scanner, and you can plan the intervention. It's what we will do today with our patient. It's called the one-day implant. Why? Because I have the patient, I plan the surgery, this is the planning, and this is the digital eye. I will show you what means digital eye. And I get this, the guide. This is a final zirconia abutment, and this is a provisional crown. Now we do it one piece without any cement. Yeah? And this is the guide. We have the same situation today. What's happening? Let's see. It goes? Yeah. I will make the music a little bit, because I want to explain what's happening. Yeah? First, you have to adapt the guide to know that the guide have some small windows here to see that the guide is perfectly seated on the neighboring teeth. Yeah? And you have a hole, and you have a kit, and you just go in with the burrs, keeping in your head what was in your eyes before. Your eyes are not useful now, but your feeling of density of the bone is important. Yeah? Because you just prepare the bone, but you expect at the end of the intervention to have a good primary stability to be able to load this implant. And this is the magic of this implant. And I'm using this since 2012, and I changed my protocol since I'm using this implant, because it's very stable. You can make a shorter time of treatment for the patient. And you place the implant through the hole, and you have to get the perfect stability, and then you can load it immediately. This green stuff is to position the hex and the depth. I will talk to you later about this. I think we will need the whole day, huh? We stay here. Good. So the insertion torque and this small windows is important. Yeah? With a guide. Remove the guide. I'm always checking what is happening. I trust the guide, but not 100%. Yeah? You know what it means, perfect trust, but absolute control. And this is absolute control, and you just place the crown and make the prosthetic setting. We will do this today, exactly the same. After placing the implant, I'm re-preparing here the pocket, and placing the second gingival graft. So I did once when I developed the site 6 months ago, and now I'm doing a new one together with the implant placement. It's just one suture to take inside the graft. You don't need anything else because you make the fixation. Here is the graft. You make the fixation of the graft with your crown. By screwing your crown, you stabilize the graft. You don't need many sutures in this situation. Yeah? This is the abutment. It's one suture. And this is immediately and 1 week after with the healing. And he goes out, like our patient will go out today, with the implant. And this was in 2015. I was not happy with the papilla between implants. You know the papilla between implants, it's always hard to get. But because of the double CTG, I have the potential of growing, and the papilla improves. And look at the position of the implant. It is perfect because it was planned before. I had time to plan it before. What is the conclusion? It's a single implant. It's a flapless guided implant with R2 gate. I had totally missing the coronal part of the buccal bone plate, and we did the preservation with membrane first to separate the soft tissue from the hard tissue, and then the allograft, the allodine. Connective tissue 2 times from the tuberosity. The good thing is after 6 months, you can harvest the same tuberosity because it's back. The tissue is back there. You can make it several times. So the socket preservation is very important, and also 1-day implant if you want to hurry a little bit. But in order to hurry, you need good tissues. The third protocol, this one is from Transylvania. Look at this natural canine, yeah? It's natural, nobody touched it, yeah? And it's functional, the guidance is perfect, yeah? But he's having a falling premolar. It was apicectomy before, but nowadays it's fractured, it's cracked, and it has the indication of extraction. Yeah? The extraction, always cut it, and I will have a good socket. I have the septum here, so this is a perfect situation for immediate implant placement. It's safe. I don't want to tell you to go out from your comfort zone and something that is not safe. If it's not safe, do the socket preservation, do the graft, and then you place the implant. It's okay. The final result is important. And remember, this is a hole. Yeah? We saw it on the CBCT. I don't want to open the flap, and I cannot graft it only from the alveolus. So I'm doing only a small incision in the mobile mucosa. It's vertical, not to interfere with the vascularization. And through this window, I have access to the hole. You see, partially here is the hole of the bone. So I place the implant, and this is the direction. And then I'm placing allograft and a resorbable membrane there to cover the destroyed window. And this is the beautiful CTG. Yeah? It was harvested like a free gingival graft, removing the epithelium and removing the glands and the fat. And this is what we need. It's dense, firm CTG. It's the best tissue you can get. And it was a tunnel, and I placed it on the whole buccal area to improve what? What we were talking at the biology consideration. The thickness of the mucosa, because the thickness of the mucosa gives the stability of the bone. Good. Fixation with a few sutures, and very early, 10 days postoperatively, you can already make the impression. Look, this is the place I harvested. Yeah? It's only 10 days postoperatively. It's healed. already healed. And provisional, always provisional, to play with the shape. And this is 2018. Look at the amount of bone that I have here, because it was a double root tooth. So I fill everything with allograft here. What I learned from here, from this, it's a single implant, it's immediately placed, freehand, and because it was the partially missing, but it was in the apical part, I was able to just graft it and to make this small incision to make the reconstruction there, and the subepithelial connective tissue graft from the molar area. The next protocol. Are you still energy? Yeah? So this was with destroyed. This protocol is the best one. Why? Because I have everything. I have the bone, I have the bone plate, I have the soft tissue. Look here, we have a thick biotype. So it's okay. I just remove the tooth. I have some inflammation here distally. The papilla was inflamed. And I place the implant and I graft with allograft the buccal plate, the buccal gap. Why? Because remember the Ferrous paper in which they say the dimension of the gap is very important in the remodeling. So I want to graft that gap to have very stable bone in that area. And I harvest again from the tuberosity. This is the CTG from the tuberosity, and this will be the final position of this. Yeah? And I just take it through a pouch, a small pocket there, and I make the fixation. And I leave it to heal, and I make the screw-retained crown. And this is the result at the end, and this is the result. And you still see the remodeling. Look here, and look here. It's a very nice remodeling, but I don't lose anything from the papillas, and the shape is, after 5 years, intact, because I have enough bone in the buccal area, and I have enough thickness of the mucosa. This is to be kept in mind. Yeah? So, single implants, freehand, immediate, intact buccal bone plate, socket preservation, allograft, tuberosity, CTG, pouch technique. This is the standard protocol. This is when you don't have any particular situation. Good. The fifth is a bit special. Yeah? This lady, it was not me who implanted this, it was my colleague, and it was destroyed an internal resorption of this central incisor to be extracted. And he placed the implant, and then it was with screw-retained provisional, but the lady didn't like the appearance, the cosmetic appearance. So looking a little bit, what is the problem? Always in the frontal area, when you place the implant a little bit more palatal, according to the law, you have this concavity. Here is the root is near the bone. Here, the root, the artificial root, the implant, is a little bit palatal. So I have this gap, and if I'm looking from lateral or from down, I have this concavity. What can I do for this? 1.5 millimeters maybe. I'm harvesting the magic CTG from the tuberosity, and then I'm unscrewing. From this position, looks quite decent, but it's not enough. So what can you do? You can do it even after 5 years. You unscrew the crown, and you make the incision only in the sulcus. Nobody sees anything. You make the incision here, in the sulcus. You dissect, you make a pouch, a pocket there, and you just place a CTG there. And you fixate the CTG with your crown. You don't need any suture inside the sulcus, because you place the crown. And the result is this one. It's a big difference. It's a very big difference. And what is interesting, this is the result. And this is the result. When you are looking at those from the lateral, you see the same angle between the tooth and the gingiva. And this is the ultimate thing for the aesthetics. Yeah? Otherwise, you will have the tooth, but it's a little bit backwards because of the position of the implant. Can you get me? Okay. And this is 5 years after. Position of the implant, very good, very stable soft tissue around the implant. It goes creeping a little bit. This zenith is lower than the other one a bit. But you can always use a laser to remove, but to build is much more difficult. So what you learn from this, that you can do a late tuberosity CT graft with pouch technique during the healing time with the provisional. Anytime you can do it, anytime. Particular situation. One very difficult case, and I will show you, is this one. A colleague called me, said, I have a case. She broke the incisor, and it's not for me, this case. Can you handle this? Well, let's see. And she came with this crown placed with composite. Looking at the CBCT, what you can see is internal resorption. Yeah? It was broken because there is no tooth there. It's a big internal resorption. But this is not all. This is her relaxed. And this is her smiling. Yeah? Well, you have to decide if you can do the restoration of the central incisor or not. Because this lady shows everything to everybody. Yeah? You cannot hide at all. And there is this root membrane or socket shield technique I'm sure you heard about. It's in fact tricking the nature. How you can trick the nature. If you extract the tooth, you will lose the bundle bone. But if you have such a thin bone like here, bundle bone is everything. If you lose the bundle bone, you lose the whole plate. Yeah? And you can keep one part, the buccal part of the root, because you keep here the periodontal apparatus, the periodontal ligaments, so you keep the bundle bone. Yeah? But you have to just cut and to make the partial extraction therapy. This is not new, but now it's fashionable. Everybody has to try this. It's not much, but you have to be very, very careful with this. But sometimes it's a good idea. This is the broken crown, and I still have something inside with a very nice burr. And Megagen developed special burrs that can make you easier that cut and that extraction. You just cut the tooth, including the apex. The apex is very important to be removed because at the apex you have the small canals. And if you leave that small canals, you cannot make them sterile. And you may experience a late infection, and you don't want this. So you have to just remove this part of the root, the palatal part, it's here, and to keep this 1 millimeter of root at the buccal. It's like 180 degrees from here to here to keep my papillus in place. Yeah? The point is to place the implant behind the shield, not touching it, because if you touch it, you just displace it and you have to extract it. Yeah? So this is the position of the implant. The magic of this AnyRidge is that you have 78 ISQ for an immediate. You cannot believe it. I was not believing when somebody told me that try this. I change all my protocols. I don't wait anymore so long for the implants. Of course, if I'm doing the big GBR in the lateral area, I'm not doing immediate loading. But in native bone, you can do it for sure, if you make the proper preparation of the bone. And this is between 3 and 4 millimeters, this black line of the insertion tool. And you just place the implant and then make the scan, allograft, scan, no nothing at all, but delivering the next day the crown, the screw retained crown. And look, this is the socket. Yeah? This is the socket. It's very thin, it's very delicate, but it keeps the bone in place. It keeps the bone in place. And this is the screw retain. You see, it's no cement, it's nothing, and you just place it. It's too much pressure, and then you prepare the S shape, the place where the soft tissue will be stable, by removing and adding and removing and creating that prosthetic S shape, which is very important for the stability of the tissues. Yeah? And you end up with this situation. With this situation, look at the angle between the gingiva and the crown. It's natural. Yeah? You cannot say that this one is an implant, only if you're experienced, very experienced. And the lady, it's happy. She is happy. Look at the smile. Huh? She needs a Lefford one, for sure. What are the advantages or disadvantages about this socket shield? Advantages is no material, is no comorbidity, it's one surgery, but we don't know long term. There are published some long-term results, 10 years, but all of them, it's a friend of mine, the publisher, and I ask, you don't have only, it's 100%. I really don't like this 100% because in medicine, you hardly can find 100% of success. But we have to give credit to this. What we understand from this case is that we can use this partial extraction therapy in some cases in which you don't have other choices or you have high-risk choices. Yeah? The seventh protocol is this lady, look at her, she had a bicycle accident. You have to stop me when it's over, okay? We have time up to 11 only, and we have to operate also. Complicated. This is the situation. I will go a little bit quicker. This is her situation. This is the clinical situation. This is the OPG with the fracture in the middle part of the root. It's fracture, everything. And this is on the CBCT. You can see the fracture line, so it's no future for these roots. I cannot do anything because it's not very nice, the level of the fracture. So I extract this. I try to make the socket shield technique on these two. I lose one, and I have this situation. Yeah? This is the socket shield. I leave one part of the root at this area. And I have to decide what I decide. How many implants to place here? Do I place 4 implants or do I place only 2? Lateral, and the pontic. The guides told me to do lateral, and my experience, it's safe. Yeah? And you make the ovate pontics. But this lady had a good mesiodistal distance. Yeah? So this distance, so big crowns, allowed me to place separate implants. So this is the socket shield. Look, the apex is there. What I cut, it's only a part of the root, which is there. The rest, it's out. And this is my thing. I place 4 implants because I have enough space between them. And these are the implants, hand placing, not guide. And here is the socket. Here is the crown, and here is the implant. Again, very good primary stability with any ridge, grafting, and immediate impression, or scan. Now, you can make the impression or scan, and you can load it. This is our screw-retained crowns. Of course, we have to work on the papillas. You see the space left for the papillas to come down. And this is working on the provisionals and having this angle, this lateral angle, which gives the aesthetics on this restoration. The position of the implants, this is hand placed. I was lucky again. And she is smiling. Of course, is my patient. She shows everything. Yeah? This is the rule. And this is the stability of the tissue 3 years after. Yeah? With very nice position, and this is hand position of the implant, not guide. And this is the CBCT position. Yeah? And look at her, how she smiles. But now, after 3 years, he changed maybe the plastic surgeon, because you see here is the asymmetry. The injection was not balanced. Yeah? Before, it was better, the position of the lip. But now, the left side of the lip is lower. Maybe the injection was not so good. We were laughing together about this. So, multiple implants, free hand placement, partial root extraction, socket preservation with xenograft or allograft, and no CTG. Full arch. Full arch, this lady with this situation. Failing teeth, taking a look at the CBCT, if it's possible to make immediate implant placement. It is possible to make the immediate implant placement because she's a class 2 per 2 anomaly. And this is good like a position of the roots, but is not good like occlusion. Yeah? But problem stays 3D implant position. Yeah? How we can do it, especially in the maxilla, especially in class 2 deformity. It's hard. And we plan it. We plan it with R2 gate, 6 implants. I don't use all on 4. I like all on 6. I think 6 is safe than 4, safer than 4. And this is the digital eye, the magic eye, who gives me a color code of the density of the bone. Yeah? It's like a colored CBCT. The guide and the fixation pins. I'm fixating the guide, and I'm just preparing the bone with the burrs and placing 6 implants position. And this is the position of the obtained implants. Yeah? And now you don't have to use the provision. You can use only the guide. Yeah? And with this guide, this is the placement of the implants. It's the perfect placement. This situation, you cannot do it without the guide, unfortunately. And the ISQ machine, that gives you the idea of the stability bone-to-implant contact and allows you to make the immediate loading. It was only one with 58, and this one was not loaded. It was, we were waiting for this. And this is the immediate provisional. Usually we make 2 provisional in full arches. The first one is the not beautiful one, but the patient have the teeth to go out from the practice. And then after the tissues are healed, this is the first one, yeah? After the tissues are healed, we perform the second one, in which we discuss with the patient length, midline, ovate pontics, to shape the soft tissue. Yeah? And this is her with the provisional. And then we change the provisional with the final, copying the final. But she told us that she wants big white teeth because her husband remembers her with the big teeth. For me, it was too big, but she loves the appearance of the teeth. She told me that when she was young, she was smiling like that. Yeah? Of course, it was a class 2 patient. Yeah? And this is the full arch. And here it's mandatory to use a guided implant placement because otherwise it's very difficult. Yeah? I don't know if we have time for the management of complication. I propose you to continue with the case because I don't know where are the organizer. We have the room only to 11 o'clock, or we can go further. I don't know what is next. Is nobody from the organizing committee here? No. No. There is. I'm sorry, Elisa, at 11 o'clock we have to go out. Okay. We will hurry. Okay. Okay. So let's go directly. I promise that for the management of complication, I'll come back in Sofia. And we go with the take-home message, I think is important. We will hurry. Okay, good. The take-home message about this different clinical protocols. You saw it was no one like the other one. It was different choices guided from different clinical situation. And about the 3D positioning of the implant, yeah? You can have single implants. For single implants, if you are experienced enough, you can use freehand. But use orthogate as one-day implant. What means one-day implant? Means that I place the implant and I already have the prosthetics, yeah? Like we do today, here. In multiple, it's okay to place them freehand if you have landmarks. If you don't have landmarks, it's better to do it with a guide. Yeah? It's recommended to do it with a guide. For full arch, for the mandible, it's difficult, but it's achievable. Impossible in maxilla, because maxilla is a pyramidal shape, and you cannot place parallel the implants. Yeah? They have to be a little bit split, and you cannot do it by freehanded without any landmark on a edentulous patient, or it's hard, or you can miss. My colleagues from the prosthetics, I'm not doing prosthetics, only surgery, they call me and they show me on the model, when they receive the model, where are the screws, and they show, this one, you have to be more careful, because the screw is not in the perfect position. The exit of the screw is not in the perfect position. So doing your own prosthetics or being in a very good connection with your prosthetician, you learn a lot about placing the implants. Yeah? Orthogate is mandatory. In ridge preservation, augmentation, you can do it immediately with implant installation. You can do it when you have intact bone plate. Yeah? Or when the buccal bone plate is missing in the apical part. You can do it before implant installation, when total or coronal part of the bone plate is missing. Yeah? You have to do it before, to be sure, to be safe. And the CTG, the best is from tuberosity. If not available, the second choice it will be de-epithelialized CTG from the molar area, as you saw. Thickness is not big. It's between 1.2, 1.5 millimeters maximum, not more than this. Otherwise, you can risk a necrosis of this tissue. And only lamina, without fat or glandular tissue. I don't like when I see live surgeries or demonstration when they leave in place the good part of the soft tissue and they take the deep part with periosteum, with glands, and with fat. This will disappear from there. And it's also more painful because in the deeper part, there are the nerves, the sensitive nerves. And you can do it when? With socket preservation before implant placement. Before implant placement and with implant placement, both, like we saw. After implant placement, when we have the provisional, the screw retain, or any time for aesthetic improvement. You can just make the pocket and place for the improvement a CTG. I thank you so much. It was a long, we begin a bit early, a bit late, and then it was very interesting. You seem to be very interested, so I was very, I explained a lot, and this takes time. And I propose you to see what we will do. We will do a live surgery now with an immediate implant placement, with immediate loading, we hope, with a guided. The guide is already done. It's here. The patient is here, so we can prepare. But before, I will show you a little bit the details of the intervention to be more easy for you to understand. So what is this Artogate? It's a software, in fact. It's a software in which you can play the position of the implant and you can do the analysis of the bone. What is the principle of the guide? Very shortly, is having a CBCT and a STL file. The CBCT is the DICOM. It's a X-ray acquisition, and the STL is a scan acquisition. Why we need both? Because with this CBCT, we have the bone and the teeth. Yeah? We have perfectly the bone and the teeth, but we have an inaccuracy of over 200 microns. So we cannot make the plan only on CBCT for CAD-CAM, because we will have a lot of errors. But with the scanner or the intraoral scanner, the accuracy is under 50 microns. So what we do, in fact, we try to, but we cannot see the bone. We try to merge this scan with the CBCT. This is a software for merging them and planning the position. This is the standard. All the guides has this protocol. But to immediately load the implants, we have to know what is the quality of the bone. And this is a color-coded CBCT in which we have the green, which is animal, the yellow is the cortical, the blue and the red is the spongiosa. So this is very high density, this is nothing density. The black is the air. So you can see the spot where you place the implant, and you know if you can load it or not. Because not always you can load it. Sometimes it's so soft, the bone, so you have to leave the implant for osteointegration. Yeah? So you just check the bone, and in D1 and D2, you can immediately place the implant and load it. In D3 and D3, you can do it also. In D4, 5, it's better to wait for the healing. So in D1, D2, single implant. In D4 and D5, single implant is contraindication, or you can connect splitting the implants for the loading. And this is a small movie to understand. I hope it goes. Yes. To understand what we do, in fact, to prepare. So we take the impression of the patient first. This is the missing tooth. This is the protocol of making this. It's a tray, and we scan the patient or we make the cast to be scanned. It depends on if you have a scanner in your practice or you don't have the scanner in your practice. And then you use this R2 tray. This tray is radio opaque. You can see this tray on the CBCT. Why? Because you need points to merge them, the STL5 and the CBCT. And with this tray in mouth, you make the acquisition, the CBCT. You can print or you can classically make your model. If it depends if you have the scanner or you don't have the scanner, but it doesn't matter on the final situation. And you have what we have. I will show you. We scan the cast. Is the digitalization. This is the classic situation. When you have the intraoral scanner, it's easier. You scan it and you have it already. You have the maxillary, the mandible model. You scan the R2 tray model in order to be merged, to have landmarks to be merged, and the final. If you don't have a scanner extraoral, you can send the cast to the guys from the center, and they will scan it for you. And then you have the virtual surgery. You plan the position of the implant, and you plan where the screw will be. You plan everything on the CBCT and on the model. And this is the guide. If the gingiva is good, the thickness of the gingiva is good, you go with any flapless, and you go with the burr up to the lowest level. You just place the burr. It's very, very easy. Take care to have enough water, coolant, and don't do it with high speed. because you want to feel the bone. You want to feel the density of the bone. And you go with the smallest on the whole length, and only the cortical if you need. Yeah, this is shorter only for the cortical in the coronal part. Yeah? Taking care not to move, these windows of the guide are made to see that the guide is in proper position. Yeah? And you just place the implant. This is the line for the depth, and these green lines have here a small window to adjust the position of the hex, yeah? Because you want to place the crown. Or you can choose a non-hexed crown, like we have today, and gives you more freedom. Yeah? You place it inside, and you stop at this level. Stop here, and then with the insertion torch, you just place the implant at to feel the torque. You need the torque, and then you need the ISQ. We will have the torque now today, but we don't have the ISQ machine. This is the vertical position, and then we put the green in the window to have the hex position. Yeah? It's logical. Apicocoronal position and hex position. This is important. After that, we remove the guide. If we have a good insertion torque, we can load it. If not, we just end the intervention. ISQ, we need it over 70 to be able to load it. Abutment, crown, and that's all. And this is our patient, Casimir. We thank you that he is here. And this is his situation. And we need to implant this area, 36 and 37. We have enough keratinized tissue to do it without any flapless. And this is the analysis of the bone, the position of the bone, the first implant, the digital eye. This is the position of the screw. This is a little bit lingual. This is in the center. And the second implant. And we know the length. We know everything. It's good to have different diameters of the implant. If with one diameter you think it's too loose, the implant, you can use a bigger diameter and to compress more the bone. The idea is it's absolutely okay to compress the bone with this implant. And this is the guide. We have it. And we show that we have keratinized attached gingiva in the holes. So this we'll do now, today. So we begin. Danny? If you have questions, please.